Okay, so chronic diarrhea, I'd go along with that to some extent, and just collaborating with you on this, since the title of our talk is, okay, so what do you think your diagnosis is? Could be IBS, okay. So, because again, and I mean, this really illustrates a basic point that I want to get across, is the fact that when we say irritable bowel syndrome, what it means is simply abdominal discomfort, whether the person characterizes it as bloating or cramping or stabbing pain, that's associated with altered bowel habits. And that may mean a change in the frequency of passing stool, only passing stool 1 to 2 times a week, or passing stool 4 or 5 times a week, or changes in stool consistency. And really, that's more common for me. In my exam rooms, I have all these 8 by 11 glossy, laminated charts of the Bristol stool scale. If you get excited in medical school about looking at this, yes, you're probably going to want to become a gastroenterologist. But I actually show these to my patients when they tell me, they've got some changes in their bowel habits. And, a patient may say to me, I pass stool almost every day, but when I do pass stool once or twice a day, it comes out like this. Well, they may not have diarrhea in terms of passing stool 5 or 6 times a day, but in terms of having a very watery stool consistency, yeah, they've got diarrhea. And if that's associated with when they get their cramping and bloating, that's irritable bowel syndrome. So during my 30 minutes here, I'll talk a little bit about the pathophysiologic cause of irritable bowel syndrome, a diagnostic approach for the general internal medicine physician about a patient who presents like this, as well as looking at the randomized control trial data about what treatments have been shown to work, utilizing that evidence-based medicine philosophy. Now, the first thing that's so important to do is to actually explain to the patient what's causing these symptoms. A lot of times patients may have seen a couple of different doctors. They've got the belly pain, loose stools, and maybe they saw another GI doc who did a colonoscopy on them, but they're seeing you, and they've been told they have irritable bowel syndrome, which a lot of times translates to patients as a waste bucket term, which simply means, yeah, we did a bunch of tests and we can't find anything, so we're going to label you as irritable bowel syndrome. And that's really disconcerting to patients because this is a problem of the function of the intestinal tract. What I'm going to talk about here is a little bit oversimplified for the gastroenterologist, but I still think it's helpful for the GI fellows to think about how they may want to explain this to patients. So first, what we're saying is, again, this is not a structural disorder. It's a functional disorder. And dysmotility, meaning the smooth muscle in the colon isn't squeezing in a timely and coordinated fashion in order to transit the stool through the colon in order to pass, a stool 1 to 2 times a day that's soft and semi-formed. And that smooth muscle may go into spasm, squeezing down real hard, causing you to have cramps. And if the muscle is squeezing too slowly and the stool sits in there for a long time, you're constipated. The muscle squeezes too quickly, stool shoots through there, and you have diarrhea. So that's one component of it, dysfunction in the way the smooth muscle in your colon squeezes. The second component is visceral hypersensitivity. In other words, for a patient with irritable bowel syndrome, just distending the wall of the colon a little bit with air or water or stool triggers pain signals to go to the brain. So that's really what we mean by visceral hypersensitivity, that in fact, just a little bit of that squeezing leads all these pain signals to be sent to the brain, that the neurons that sense stretching or squeezing in the colon are hyperactive. And that's important because that's another target for us in treatment. So when I'm talking to a patient, I use a picture like this to try to emphasize a few basic points. Again, this is a real disorder, and I can tell you that part of the problem is in a normal person, that muscle in the colon squeezes in a coordinated fashion, and most of the water that enters the colon gets absorbed, and you pass stool once or twice a day, and you don't have any abdominal pain. But in IBS, that muscle's not squeezing properly. So that's a real problem that you have. I'm not saying you have just a waste bucket term of irritable bowel syndrome. And that when that smooth muscle squeezes spasmodically, you can feel like somebody's reaching in there, and you feel like you have a cramp or a Charlie horse. And if the muscle squeezes too quickly, and the other part of the problem is that these afferent pain neurons that again are the neurons that send the pain signals to the brain, they're hyperactive. A little bit of stretching or squeezing, and you get all these pain signals sent to the brain. So again, my point there is taking a couple of minutes to explain to the patient what irritable bowel syndrome is can be one of the most important therapeutic interventions that you make. Because I can't tell you the number of times, for me, as part of the GI, specialized GI motility group at the University of Michigan, where I see patients that are sent to me usually after they've seen a couple of GI docs, and I simply say to them, you've been labeled irritable bowel syndrome. What's that mean to you? And they shrug because they really haven't been educated. It's like, well, that's what I was told I had because they couldn't find anything else causing my symptoms. And hold on to that point again in a second. It's what I've been told I have because they couldn't find anything else that caused my symptoms. But before I address that point, I do want to go over just a little bit more about pathophysiology. What are the underlying problems that cause those functional disorders? And there are a lot. Again, this is a real disorder with an underlying pathophysiology. Now, if you've had your gallbladder taken out, you may have bile acid malabsorption. That can create these symptoms. There can definitely be alterations in the way the brain communicates with the enteric nervous system in the gut, and again, creating problems with how those smooth muscles squeeze and how they sense stretching. And part of that idea can be because there are abnormalities in the way serotonin signaling occurs in the enteric nervous system. I mean, we're all familiar with using SSRIs, like, say, citalopram, which is Celexa, and, Zoloft or Prozac, which are the much older ones. But, most of the serotonin in the body is actually in the enteric nervous system in the gut. So if there are issues of serotonin signaling, that can cause these symptoms. We certainly are aware that if a person has had an episode of gastroenteritis, whether it be bacterial or viral, they're 4 times more likely in the next 12 months to develop IBS symptoms compared to a healthy control. And that's because we have evidence that that triggers mucosal inflammation. And finally, if a person has celiac disease, that mimics IBS symptoms, but also we're getting more information about people who don't truly have celiac disease, but have gluten insensitivity. And the analogy I use, think about lactose malabsorption. You do produce some lactase enzyme, and you can tolerate some dairy products, but too much creates symptoms of bloating and diarrhea. For people with gluten insensitivity, which is really appearing to be a real disorder, they don't have the true allergic reaction of celiac disease to gluten, but their ability to digest gluten is limited. And decreasing gluten intake may improve those IBS symptoms. So those are some of the underlying pathophysiologic problems. I will note just quickly again, the issue with serotonin signaling. If there are defects in serotonin receptors or production of serotonin in the enteric nervous system, the ability of that to cause IBS symptoms is just enormous because this is the lumen of the colon. and you have enterochromaffin cells that have to release serotonin and then stimulate the intrinsic primary afferent neurons here. And then that goes to motor neurons that are telling the smooth muscle how to squeeze, as well as getting feedback as that squeezing occurs to afferent pain neurons that then send signals up to the brain. It's a very complex system, but again, this is one of the areas we can target with our treatments. And going back to this idea of post-infectious IBS, after these episodes of, say, a viral or a bacterial gastroenteritis, we can really say that we see all kinds of inflammatory changes, an increase in mast cells in the colonic mucosa. They are much more likely to have degranulation of those mast cells, triggering an inflammatory response. We do see an increase in different inflammatory cells in the colonic mucosa. And the reason that's of interest is because when we use different treatments to modify the bacterial flora in the colon, that may help resolve these inflammatory changes. So, okay, all the internal medicine residents and medical students look like they're sitting over here. Is that correct? That's just an assumption on my part. Okay? I see some very skittish looks over here when I say that. Don't worry, this is basic. I didn't get a chance to memorize any names from over here, but I'll look across the next to last row right here. Okay, irritable bowel syndrome is not going to kill anybody. Why do you think you might want to know about it? Okay, impacts quality of life. What might be one other thing? If you go into general internal medicine and you have your list of 20 patients that you're going to see that day, any idea how many of them may talk about irritable bowel syndrome symptoms? Think it'll be at least a few? Yeah, so it's real common. And not just real common, but these people go see the physician a lot. Again, this is oversimplified, but IBS is present in at least 10% of the U.S. population, although only a minority of those patients go to see the physician for care. It's not going to kill anybody. It's not a fatal disorder. But, I think all of us, either personally or have family members, where if you've got a lot of difficulty with digestion, really bad diarrhea, really bad constipation, really frequent cramping in your abdomen, that makes you pretty miserable and really impacts your ability to do your daily activities. So, sure, it's not fatal, but if you're able to treat it effectively, it can really make a big difference in people's lives. And again, other reason why we have to know about it is, this is a big part of our practice. In GI, functional GI disorders make up really the majority of our practice. And in general internal medicine, among the GI disorders that you'll see in your patients, irritable bowel syndrome will be the most common disorder, up there with gastroesophageal reflux, that you'll have to deal with in your practice. So that's why you really need to know about this. Okay, let's go back to our patient Doris. So again, for 15 years, she's had bloating, cramping, some loose watery stools. She doesn't have any danger signs like a family history of colon cancer or blood in her stools or unexpected weight loss. So what diagnostic tests does she need? Now I'm going to make this a tiny bit tricky because I'm going to go up to the GI fellows up there. So Michael Carthy and Michael number 2, what do you think? What diagnostic test? This patient shows up in your clinic, and let's say she hasn't had anything done before except for a CBC that showed no anemia and a C-reactive protein that was normal and a comprehensive metabolic profile that was normal. So basic labs are normal. So what diagnostic test does she need? Going to do an EGD and colonoscopy. I mean, you go to Midas, you're going to get a muffler. You come to a GI doc, you're going to get scoped. Okay. And I don't mean to tease Michael too much. If you come to a GI doctor with these kind of symptoms, there is usually an expectation on the part of the patient that you're going to get scoped. and there's an expectation on the part of your referring primary care physician that the patient will get scoped. So Karthi, Michael wants to do an upper endoscopy and a colonoscopy on her. What's the likelihood that you're going to find another disorder like, say, Crohn's disease or colon cancer, microscopic colitis, peptic ulcer, something else like that, that is the true cause of these symptoms, not IBS? What do you think that likelihood is? Low. How low do you want to go, other Michael? 1%, 5%, 10%? Those are all low numbers. 5%. Karthi, do you want to go any lower? Hint. Less than 1%. Okay? Here's a key point here. Okay. Should any diagnostic test be ordered routinely when a patient presents with these symptoms? Remember, this woman's had these symptoms for over 15 years. If she's got colon cancer, yeah, bad things would have happened a long time ago. If she's had Crohn's disease for 15 years, believe me, bad things would have happened a long time ago. You may get a rare case of Crohn's disease, but this has been present for a long time with no danger signs. Really, the only diagnostic tests that I would suggest are getting a CBC to look for anemia and a C-reactive protein, because if it's elevated, it might be Crohn's disease. And that would trigger me to do interventional diagnostic tests. So, but the main point here is this. I don't need to do a bunch of diagnostic tests when a patient presents with 15 years of bloating and cramping that's associated with some diarrhea to say you've got irritable bowel syndrome. We frequently hear IBS is a diagnosis of exclusion. I need to run certain tests before I say that. No. You can make a positive diagnosis of IBS just based on the symptoms, because why make it a diagnosis of exclusion if I know the likelihood of any other disease being the cause of these symptoms is less than 1%. So again, just to emphasize, when they see you in internal medicine clinic, sure, get a CBC because anemia is a danger sign. Get a C-reactive protein because if that's elevated, it could be Crohn's disease and that's a danger sign. And look for other red flags. I mean, certainly if a patient has the onset of new symptoms after the age of 50, in that patient population, that's a danger sign. If they're anemic, if they wake up in the middle of the night with diarrhea from a deep sleep, unexplained weight loss, a family history of organic GI disease like colorectal cancer or Crohn's, sure, that triggers tests to look for structural abnormalities. But remember, this is a disease of function. So, if it's a disease of function, why am I going to do a colonoscopy in a patient who has a disease of function? I'm doing a colonoscopy to make sure I don't see a structural defect, but if I compare, in this study, 500 IBS, approximately 500 IBS patients with 500 controls, well, in fact, 1 out of the 500 controls had colon cancer versus 0 of the IBS patients. 2 out of the 500 IBS patients had Crohn's disease. And 1.5% had microscopic colitis. So you might look at those numbers and say, well, gosh, every once in a while I'm going to find microscopic colitis. Every once in a while I'm going to find Crohn's disease. And the final thing I would say about that, when we talk about red flags, hey, another red flag to me is if the patient hasn't responded to conventional therapy. You don't need to start out with a bunch of diagnostic tests. Go right to therapy. And then if the patient doesn't respond, hey, by all means, then go ahead and do other diagnostic tests, because then when they go to Michael and he does his EGD and colonoscopy, if the patient does have microscopic colitis, that's the time we'll find it. Okay? So it's a positive diagnosis, not a diagnosis of exclusion if I run every single test I can think of, and the likelihood of me finding another cause for those symptoms is less than 1%. Okay, now, a lot of times we're also told to screen for celiac disease. In fact, now this is more for the GI docs, and again, I'll try to get a little bit of feedback. So Amar, Don, John, I mean, I'm going to kind of guess here. If a patient comes in with IBS symptoms, more with diarrhea, and they haven't been screened for celiac disease, you've been taught routinely that's what you should do. I mean, I'll add, during my training and what I've trained a lot of GI fellows in is that they should routinely check for that in patients with IBS-D, right? Nodding heads a little bit? Okay. Just making sure you guys are awake back there. I know it's early. Okay. That's the case if you're in parts of Northern Europe where the prevalence of celiac disease in the population is at least a couple of percent. But in the U.S., the prevalence of celiac disease is less than 1%. And when we do screening studies in the general population versus people with IBS with diarrhea, we actually don't see an increased rate of celiac disease in the IBS-D patients. What we do see in those IBS-D patients is that we're seeing higher and higher rates of patients that are responding to a gluten-free diet that may have a gluten insensitivity. Because again, as of 2013, 2014, we're finding that, again, more and more patients without celiac disease feel that their symptoms get better by avoiding gluten. And there's some data, again, to really show that this is true, that it's not just a diet fad. But I'm not saying not to screen for celiac disease, absolutely. If you don't identify celiac disease, lots of bad things can happen downstream. But this is a change in orthodoxy. Really, in the U.S. population where the prevalence is less than 1%, there's probably not much of an increase, if any, in the likelihood of finding celiac disease in the IBS-D patient compared to a healthy control. Okay, now we're on to treatment. Let's think about, and let me see. Okay, I'm not doing too bad on time. So we've got our patient, Doris. And again, from a general internal medicine perspective, I've only done so far a CBC. She's not anemic. I've done a C-reactive protein. That's normal. She's African American, so that's another reason I'm not worried about celiac disease. And again, this has been present for 15 years. So what treatment am I going to give her? If she had mainly constipation symptoms versus diarrhea symptoms, I'm going to address it first, saying she mainly has constipation symptoms. Okay, so, well, I guess I gave that away when I put that up. So point number 4, start with diet changes, okay? So what kind of diet changes do we want to recommend? This is basic. This is kind of common sense, but it is worth reinforcing to your patients. A lot of these patients may have some lactose intolerance, causing them to be bloated and to have some loose stools. It's fine to tell them initially to try to avoid lactose products. Most of these patients, if you ask, have already identified some trigger foods. They may say, you know what, when I eat broccoli or asparagus, I get so bloated and then get constipated. And they already know to avoid those foods, but you want to try to elicit that. And you do want to ask them to increase fiber. Those are very reasonable conservative measures to do. And what's also helpful is that patients themselves will tell you the things that are most helpful for them. Eating smaller meals, avoiding fat, increasing the fiber, avoiding milk products. 60% of patients can say that their symptoms are worse after meals, and by doing these things, they found they can reduce symptoms. Okay. So that's good basic stuff. Now, again, I talked about gluten insensitivity. This is more for the GI fellows. When the patient says to you they find a big difference in their symptoms, especially of bloating and diarrhea, when they avoid gluten products, and you've tested them for celiac disease, you've done the genomic testing, and there's no evidence that they have a genotype compatible with celiac disease, and they say they get a lot better, that's not just all in their head. That may truly be a real phenomena for them. So keep that part in mind. Now, so for the GI docs, let me just double check where I am in my deck. Okay, so again, just to reinforce, lactose intolerance, look for the trigger foods, increase your soluble fiber intake. Those are all the basics to do. Now, Lashonda? No. Michael, who's behind you who's a GI fellow? Latanya. I'm sorry, Latanya. So Latanya, after you get done with doing those basics, what's the next step you can take since you're a gastroenterologist in terms of diet for these patients? What do you want to do if you want to get more intensive about diet changes? Okay. Okay. So what Latanya said was low FODMAP diets. So I'm just curious, how many of you, by a show of hands, have heard of low FODMAP diets? Okay, a few, mainly the GI docs. The idea with low FODMAP diets is that you're eliminating foods that after the nutrients have been digested, that you have a lot of short and medium chain fatty acids going into the colon. Again, this is a bit of an oversimplification, but to hopefully make it easier to understand, when those short and medium chain fatty acids haven't been digested and they enter the colon, bacteria that live in the colon, for them, that's one of their favorite food sources. They see those short and medium chain fatty acids, they multiply like crazy, and the byproduct of that is literally methane gas. And people get really bloated. And that if you have people on a low FODMAP diet where you avoid these foods, then you're essentially starving those bacteria in your colon. They're not producing much methane, and you can see a big difference primarily in the IBS symptom of bloating. Now, having said that, let me go back to you, Latanya. So whenever you tell a patient, I want you to be on a low FODMAP diet, and you give them a handout saying, here are the foods to avoid, I see Michael already shaking his head. It's not working so well for you? You mean the patients aren't able to follow a diet where they have to eliminate honey, apples, pears, wheat, rye, onions, apricots, peaches, lentils, cabbage, Brussels sprouts, green beans, legumes, where you have to take all those things out? They don't do well once you've eliminated 50% or more of their diet? Okay, not so well. Okay. Here is really a key point for the GI docs more. Our experience, at least at the University of Michigan, is don't have patients try to start a low FODMAP diet on their own. If you have them started on their own, because it's a pretty complicated diet, they're going to come back to you in a couple of months saying, no, it didn't work for me. And what that really means is that they couldn't be compliant with the diet and just kind of stopped it after a couple of weeks. Even though nutritionist visits may not be covered by insurance, most nutritionists, you can get a visit for anywhere between $50 and $75, which when you consider the copay on a lot of medicines isn't that much out of pocket. Certainly would be for Medicaid patients, but not necessarily all patients. The nutritionist will spend an hour, find out what foods the patient likes, develop a meal plan, and most importantly, patients aren't expected to stay on this low FODMAP diet indefinitely. They go through an elimination phase for about 8 weeks, and then some of these foods are begun to be added back in small amounts. And that's what the nutritionist does for you. Okay? So, again, I strongly advise if you're going to ask a patient to do a low FODMAP diet, don't just give them a handout. Don't just have your nurses talk to them for a couple of minutes. Make them see a nutritionist. Okay, so if you're going to choose your treatment, how do you focus your treatment? Focus it initially based on the primary stool pattern. Okay? Again, I literally have these 8x11 laminated glossy pictures in all my exam rooms. And if the patient says my stool is usually like this, my treatment's going to be a lot different than if they say their stool is like a type 1. So let's talk about treating IBS with constipation. You know, again, starting with fiber is a reasonable thing to do. We do have reasonably well done randomized controlled trials. This is probably the best one done in about 260 patients where they compared placebo, bran, and psyllium, psyllium being the primary ingredient you're going to see in both Citracel and Metamucil. And what they could show is over the course of month 1 and 2, less than month 3, that you consistently showed a higher percentage of patients who had improvement in global IBS symptoms, taking into account their bowel movements as well as their abdominal discomfort. So sure, start with a tablespoon of Citracel once a day in these patients. Now, osmotic laxatives for that patient who has the cramping and the bloating and constipation. This is a great example of applying evidence-based medicine, and I'll tell you why in a moment. So actually, we don't have any randomized control trials to tell us that osmotic laxatives like Miralax, 17 grams a day, is better than placebo for IBS. You know, I mean, we know if you use an osmotic laxative like Miralax, you're going to make somebody pass stool more often, but no RCT data to tell us that it not only makes their stool move more often, but it also improves their abdominal pain. So let me see again. So it's Greg behind John, correct? Okay, Greg. And you're a GI fellow, correct? Okay. So Greg, I'm sure then, from an evidence-based medicine perspective, you know there are no RCTs showing that Miralax is beneficial in IBS. In fact, that we don't have any RCTs examining this at all. So you would never use Miralax in a patient who comes in complaining of bad constipation with some cramping and bloating, right? You have two choices, yes or no. I gave you the option of saying you would never do this. Yes, you would never do this, or yes, you would use the Miralax. You would try it sometimes. Okay, here's the point. Sometimes people are too purist about what evidence-based medicine means. And when that term was coined at McMaster University by a researcher named Gordon Guyatt, that wasn't the intention to say to only use treatments that have been shown effective in randomized controlled trials. Because sometimes you have disorders where no randomized controlled trial has ever been performed. So absolutely, if they don't do well with fiber, start them on Miralax, PEG 3350, 17 grams once a day. At a minimum, you'll probably treat their constipation symptoms, even if it doesn't improve their abdominal pain. And I do want to emphasize with evidence-based medicine, the idea is that an effective physician should know the latest research developments from randomized controlled trials and use that information to help guide their treatment. But sometimes you don't have that data, or sometimes you need to integrate that data with your clinical experience. And that's another big aspect of choosing treatment for an individual patient. So, yes, if there's good randomized controlled trial data showing a particular treatment is effective versus placebo, and other randomized controlled trials showing another treatment is similar to a placebo, go with the treatment that's been shown to be effective in randomized controlled trials. But sometimes you don't have RCT data, or sometimes our patient might not fit very well into the kind of patient studied in an RCT. That's when your clinical experience comes in. Evidence-based medicine doesn't mean you treat exclusively based on RCT data. It's an integration with your clinical experience built up over time, but evidence-based medicine also means you shouldn't practice totally based on what you learned in training 10, 15 years ago and not integrate your practice with what's been found in the latest research. Okay, antidepressants. You know, when I have a patient come into my office complaining that, you know, they've seen a couple of different doctors, they've had 2 colonoscopies, they've been tried on several different medicines and it hasn't worked, you know, all they really recognize is that doctor said, oh, we can't find anything else, you have IBS. And I say to them, great, okay, I think I need to start you on Prozac and that'll be really helpful. What do you think? I'm looking back at my internal medicine residents and medical students. Is that patient going to think I'm a great doctor and have the best treatment, or think that I just consider the patient crazy and that's why I'm starting them on Prozac? The latter. Okay. Here's the point that's important to make, because I do use a lot of antidepressants in these patients. The idea is that first, tricyclic antidepressants like nortriptyline and SSRIs such as citalopram, trade name Celexa, have been shown to be beneficial for improving global IBS symptoms and abdominal pain. Now, the tricyclic antidepressants like nortriptyline probably have the most studies showing that improvement, and I'm going to use those in patients with irritable bowel syndrome with diarrhea because of the anticholinergic properties. One of the side effects of nortriptyline is that it'll cause constipation. So tricyclic antidepressants, I'll use those if it's IBS with diarrhea. SSRIs may have a little bit of effect on increasing small bowel and colonic transit, so I'm going to focus them on IBS with constipation patients. I don't want to use tricyclics there because it'll make the constipation worse. Although, if a patient doesn't respond well to tricyclics because of side effects, I'll still go ahead and use an SSRI. The key point, because I have another 8x11 glossy laminated printout in my office of this, is that when I say to the patient, okay, we're going to start Celexa, or we're going to start Cymbalta, which I frequently use. The issue is you've got all these pain signals being sent to your brain because of these hyperactive nerves in your gut. And where just a little bit of squeezing or stretching triggers pain signals to go to the brain. And the medicines we've tried so far that work on the gut haven't been doing such a great job. And we also know that the way the central nervous system communicates with the nerves here can be defective. So now I need to try a medicine that impacts the pain centers in the brain so that, again, this is oversimplified, but the way I explain it to patients is to say, if the pain centers in the brain are less active, then even if all these pain signals are being sent from the colon up to the brain, your experience of pain is less. It only takes me about a minute to do, but it's absolutely crucial before I start an antidepressant. Because if I don't say that, then, again, Carthy, if I don't go over that explanation and just say, here's your prescription for Prozac, then the patient's impression is that I'm saying the patient is simply Carthy. See, this is why I do these questions, okay? Every once in a while, just to make sure everybody's awake. So, Carthy, if I don't explain this about the way the brain-gut communication works and I just hand the patient a prescription of Prozac, then most likely the patient's interpretation is that I'm saying the patient is crazy as the cause of her symptoms, when in fact that's not the case. Okay. All right, let's talk about treating with IBS. That's great. I've got about 5 minutes, and I think we're in good shape. So, if their symptom is primarily diarrhea with abdominal pain or cramping, hey, by all means, start out with Imodium, okay? Imodium's been shown to improve stool consistency and decreased stool frequency in a couple of randomized controlled trials. By the way, I need to pause for a minute. Can anybody see the mistake on this slide? Take a moment. I do this so I can take a break to get a drink. Look and see if you can see a mistake on this slide. Okay, Dr. Roman got it. Very good. So, yeah, I purposely put stool frequency in both spots. Actually, here it's stool consistency. This is the proportion of patients on placebo and Imodium who have improvement in stool frequency. This is the proportion of patients on Imodium and placebo who get improvement in stool consistency. Doesn't impact abdominal pain, but this is based on only 2 small randomized controlled trials. Okay, and then what do you do if the patient doesn't respond to these more conservative therapies? If you do want to get more aggressive. So I will actually take a quick sip. Outside of the GI doctors, I would just want to get an idea by a show of hands. How many of you have ever prescribed rifaximin or Xifaxan, a non-absorbable antibiotic for irritable bowel syndrome, outside of the GI docs? How many of you have prescribed Linzess, linaclotide, for treatment of constipation or IBS with constipation? Again, outside of the GI docs. Okay. How about Viberzi or Luxadiline for IBS with diarrhea? And then finally, how about lubiprostone or Amitiza? Okay, 1. Okay, so after, maybe in the question and answer period, if the GI docs would like me to discuss that in more detail, I'd be happy to do that. For the general internal medicine portion of the audience, here are the things to keep in mind when you are willing to go the next step in terms of treating these patients. So, I thought that was deleted. Okay, so linaclotide or Linzess is probably the most potent thing we've had in a long time to treat irritable bowel syndrome with constipation or simple chronic idiopathic constipation. The analogy I use for the older physicians in the audience, and I'm not sure how old I look, but I finished internal medicine residency in 1992, and that was the time when we were just beginning to make the transition from using H2 receptor antagonists like Pepcid or Zantac to using proton pump inhibitors like Prilosec. And for those of us who remember that time back in the early 1990s, it was a huge advance in terms of the efficacy for treating gastroesophageal reflux, as well as peptic ulcer disease, in terms of the potency of the medication. This is a similar situation. Going from an osmotic laxative to using Linzess is really that much of a leap in terms of potency. And the way it works, okay, sorry about that. Okay, the way it works is that this is a medication. Again, linaclotide, plecanatide is the other agent that just became available. It's a guanylate cyclase C agonist. It binds to the guanylate cyclase C receptor that's in the lumen of the small intestine and the colon. So one of the key things about this is that there's virtually no absorption. At least we can't measure it in the bloodstream. Corollary to that is, if a medicine doesn't get absorbed into the bloodstream and circulated, compared to a placebo, we wouldn't expect to see much in the way of adverse events. And in fact, in the randomized controlled trials, with the exception of diarrhea, which probably would occur if you have a really effective treatment for constipation or IBS with constipation, with that exception of diarrhea, no difference in any adverse events. And when it binds here, you get an increase in cyclic GMP intracellularly. And what that leads to is the opening of the CFTR channel So chloride and bicarb go out. Sodium and water follow as an osmotic effect. And then you increase how much water is in the small intestine and colon to treat the constipation aspect. What's also happening is that you have release, that cyclic GMP moves into the submucosa, the serosa. And we can show that when we bathe these afferent pain fibers in vitro studies as well as in animal studies, that the activity of these afferent pain neurons decreases. Remember, these are the afferent pain neurons that are hyperactive and sending all the pain signals to the brain. This part, if you do use it, the improvement here takes about 8 weeks to maximize. The improvement in your bowel habits, that occurs in the first few days. So temporally, this occurs at different times, and that goes along with the idea. 2 separate effects are happening. So again, that's something that is a very safe medication. The main thing to look out for is some diarrhea because it's such a potent agent. But it's a very safe medication, and really for IBS with constipation and chronic idiopathic constipation, not just the most potent one, but actually also the medication we have the best randomized control trial data that it works. Now, if a patient has really bad bloating with IBS with diarrhea, a lot of times we have patients that on their own take probiotics. Damn, I did that again. Well, while I'm doing this, just ignore that aspect of it. How many individuals have patients that on their own have started probiotics as a treatment? I see a couple of, oh, come on, it's got to be a lot more than that their patients are on probiotics. I mean, it's a natural thing to use. By the way, when we say probiotics are a natural thing to use, be aware a couple of different studies went by the Attorney General of the state of New York in a fraud case. They've gone to 10 different health food stores, bought 10 different probiotics, took them back to the lab and cultured it. How many out of the 10 actually had in the lab culture what it said on the bottle? 5 out of 10, 9 out of 10. Go ahead, Patrick. 1 out of 10. You know, with the exception, say, of Align, which is manufactured by Procter & Gamble, and they have good data on manufacturing to show in an Align capsule, yeah, you're going to get so many hundreds of thousands of colony-forming units of Bifidobacter infanis within that capsule. Most of the probiotics that you're going to buy over the counter, yeah, excuse the GI pun, it's a crapshoot about what's actually going to be inside. But remember early on, I told you how you can get post-infectious irritable bowel syndrome. And there is very good randomized controlled trial data to show that using a non-absorbable antibiotic that seems to modulate activity of the bacteria that are right on the surface of the colonic mucosa, that it improves the IBS-D symptoms for 3 to 6 months. Has to be repeated in most patients at that time. Responder rate's about 45%, doses 550 TID for 2 weeks. I tend to find that it works best in patients with severe bloating. The other newest treatment for IBS with diarrhea is aloxatilene. That's a mixed opioid receptor agonist. It hits the mu opioid receptor, the delta opioid receptor, and the kappa opioid receptor in the small intestine and colon. 100 milligrams BID taken with food. Do not give it to somebody if they've had a cholecystectomy or they're a heavy drinker. It treats all the symptoms of IBS-D, but my own experience is that it works with severe diarrhea. Generally, I understand for the general internal medicine audience, if they haven't used much of these medications, it's something that's much more common among the GI docs. And again, I'll be happy to talk about it more with the GI docs later. But this is the next step. And really what I'm emphasizing here is if the patients try the over-the-counter therapies like Imodium and Miralax and fiber and diet changes, and that hasn't helped, don't stop there. We've got much more potent therapies to use in these patients, and that may be the right thing to trigger that referral to the GI doc. Again, if the patient's got classic symptoms of IBS for 10, 15 years, you don't need to do much in the way of diagnostic tests, maybe a CBC and a C-reactive protein, as long as they don't have danger signs. But if they haven't responded to those more conventional therapies, yeah, that should trigger your consultation with the GI doc, and then they can think about using stronger things like Linzess or rifaximin or aloxatoline, as well as getting ready to do those scopes, because the GI fellows always need more practice with scopes. Right, Michael? It gives me a thumbs up. All right, it's about 9 o'clock. Thanks very much for listening.
Thank you so much. Very well done and very nice. And you hinted about the microbiome and you hinted about probiotics. Is there more data about the microbiome and how it's different in these patients and the control population?
So we definitely have good data using genomic studies in stool that the bacterial flora in IBS patients differs from healthy controls in terms of the strains of Bifidobacter, Lactobacillus, a couple of others. I'm not a microbiologist. I'm more of a clinical trialist. But bottom line answer is yes, there are clearly differences in bacterial flora in the average IBS patient versus the average healthy control.
Okay, thank you. Questions, comments?
You mentioned lactose intolerance. Is there an objective assessment to see if someone has lactose intolerance, or is it a dietary observation?
You can certainly do lactulose breath testing to look for evidence of lactase production or lactose intolerance. So I can definitely measure it with a breath test. I tend to try to do a little bit of a simpler test, which is, I tell the patients on a day when you're off from work, like a Saturday morning, drink 2 8-ounce glasses of milk, and if that triggers all your classic symptoms, yeah, you probably have lactose intolerance. And don't necessarily take it beyond that. But sure, I can definitely do a breath test to prove it.
Is there a role for the GI doctor who's more specialized in GI motility?
Well, again, in my practice at the University of Michigan, virtually all the patients I see are sent to me from other GI doctors, where the patients have more severe manifestations of these disorders. The other things that I get patients sent to me for is if there are certain symptoms that imply they have pelvic floor dysfunction, where the puborectalis muscle is not relaxing properly, so that the issue is not constipation where the smooth muscle in the colon is not squeezing adequately, but the coordination of the pelvic floor musculature to transit stool out of the anus is disordered. Those patients usually come to me. And certainly going above the lower GI tract, I see a ton of gastroparesis patients as well.
Any other question or comment? Yep, we have someone up there. Let's start in this corner.
What is the patient population that really sometimes mixed or pain predominant?
Mm-hmm.
They aren't really having diarrhea or constipation. It's just the bloating symptoms drive traction and maybe haven't had a great response to it. What's the next step from that?
Okay. So first part of your question is if they're predominantly pain with maybe some constipation and some diarrhea. Some of you may be familiar with using, I'll use the trade names first, Bentyl, which is dicyclamine, or Levsin, which is hyoscyamine, as an antispasmodic. Bottom line there is they're placebos in the doses we use. They are not, in well-designed RCTs, significantly better than a placebo. And so, again, in my practice with more severe patients, I use a lot of Librax and Donitol. Now, those are both class 4 or level 4 drugs by the FDA. because there's a very tiny risk of dependence with them. But if you want to maximize your treatment for the pain aspect, I use Librax or Donatol. In terms of the bloating, the low FODMAP diet, when it's done properly, is probably my most effective therapy. And that's why I just want to reinforce. If you don't have a nutritionist that you're collaborating with to send these patients to, I think that's a really important thing to try to set up. It shouldn't be that hard in an institution like this. And again, even if insurance doesn't cover it, usually nutritionist visits are between $50 and $75. And compared to the copays we have on a lot of these medicines, that's not a huge amount, assuming they're not a Medicaid patient.
In the interest of time, we're only going to have one question. I saw somebody here.
When it comes to sort of when you have a mixed picture, how do you approach treatment management, neither constipation or diarrhea?
So the question was, how do I approach things if it's a mixed IBS? Sometimes they have diarrhea, sometimes they have constipation. And this bottom line answer is I have to individualize therapy. That ends up being a little bit more the art of medicine, where I have to interview the patient more carefully and get a sense of when they're predominantly diarrhea, when predominantly constipation, what might trigger each phase. But there's not a good algorithm for how to treat those folks.
You can handle one last short question.
So, Kenny, well, there was at least one study looking at estrogen receptors for,
Mm-hmm.
Nociception.
Mm-hmm.
That seems like simple therapy. Have you tried that? And so,
I have tried it. The data on that comes from pretty small studies. My clinical experience has not been good with it. So I haven't used it very often in my whole armamentarium. And maybe we just haven't found the most effective way to impact that pathophysiologic mechanism.
Thank you for joining us today.
Thank you very much.
We have a tradition of sending people back home with a Louisville slugger.
Okay.
Okay. Philip Schoenfeld, Medicine Ground Rounds, University of Louisville, May 25, 2017.
That's
Thank
awesome.
you for joining us.
Thank you so
Appreciate it.
much.
That was
I
great.
really appreciate it.
You guys have a good Thursday.